Of our discussion today is the initial management of the chronic pelvic pain. Basically, this is the RCOG guideline. Okay, so what are the possible etiological factors in the genesis of the chronic pelvic pain? There is frequently more than one component of the chronic pelvic pain, and assessment should aim to identify the contributing factor rather than to assign the causality to this single pathology. At an initial assessment, it may not be possible to identify confidently the cause of the pelvic pain. Okay, now let us discuss something about the endometriosis and adenomyosis. Okay, and pelvic pain, which varies markedly over the menstrual cycle, is likely to be attributable to the hormonally driven condition such as endometriosis. And now let us discuss adherence. Okay, there is no evidence to support the deviation of the fine adherence in the woman with a chronic pelvic pain, and deviation of the dense vascular adherence should be considered as this is associated with a pain relief. Now coming to the IBS and interstitial cystitis. Symptoms suggestive of IBS or interstitial cystitis are often present in the woman with a chronic pelvic pain, and these conditions may be a primary cause of the chronic pelvic pain and a component of the chronic pelvic pain, or a secondary effect caused by the often neurological dysfunction in the absence or in the presence of the chronic pelvic pain. Now coming to the musculoskeletal causes of the pelvic pain. Musculoskeletal pain may be primary source of the pelvic pain or an additional component resulting from the postural changes. Now coming to the nerve entrapment. Nerve entrapment in the scar tissue, fascia, or the narrow foramen may result in the pain and dysfunction in the distribution of that nerve. Coming to the psychological and social issues. Inquiry should be made regarding the psychological and social issues which commonly occurs in association with the chronic pelvic pain. Addressing these issues may be important in resolving the symptoms. Now, what should underline the initial assessment of chronic pelvic pain? Adequate time should be allowed for the initial assessment of women with a chronic pelvic pain. They need to feel that they have been able to tell their story and they have been listened to and believed. Now, many women present because they want an explanation for their pain. Often they already have a theory or a concern about the origin of the pain. These ideas should ideally be discussed at the initial consultation. Now, the multifactorial nature of the chronic pelvic pain should be discussed and explored from the start. The aim should develop a partnership between the clinician and the woman to plan a management program. Now, how would we take the history? The initial history should include the question about the pattern of the pain and its association with other problems such as psychological, bladder and the bowel symptoms, and the effect of the movement and posture on the pain. Now, symptoms alone may be used to diagnose IBS positively in this group. If the history suggests to the woman and the doctors that there is a specific non-gynecological component to the pain, refer to relevant healthcare professionals such as gastroenterologist, urologist, genitourinary medicine physician, physiotherapist, psychologist, or psychosexual counselor should be considered usually via the GP. Now coming to the examination. The examination is most usefully undertaken when there is time to explore the woman's fear and anxiety. The examiner should be prepared for the new information to be revealed at this point. Now, what investigation should be undertaken? Screening for the infection. Suitable samples to screen for infection, particularly chlamydia, trachomatis, and gonorrhea, should be taken if there is any suspicion of the pelvic inflammatory disease. Now, all the sexually active women with a chronic pelvic pain should be offered screening for the sexually transmitted infection. Now, what is the role of the TVS and MRI? TVS is an appropriate investigation to identify and assess the adnexal masses. TVS and MRI are useful to identify adenomyosis. The role of MRI in diagnosing small deposits of endometriosis is uncertain. Now, coming to diagnostic laparoscopy. Diagnostic laparoscopy has been regarded in the past as a gold standard in the diagnosis of the chronic pelvic pain. It may be better seen as a second-line investigation if the other therapeutic interventions fail. Now, diagnostic laparoscopy may have a role in developing the woman's belief about her pain. Now, what therapeutic options are available? Women with a cyclical pain should be offered a therapeutic trial using the hormonal treatment for the period of 3 to 6 months before having a diagnostic laparoscopy. Women with the IBS should be offered a trial with the antispasmodics. Women with the IBS should be encouraged to amend their diet to attempt to control the symptoms. Women should be offered appropriate analgesics to control their pain, even if no other therapeutic maneuvers are yet to be initiated. If the pain is not adequately controlled, consideration should be given to the referral to the pain management team to a specialist pelvic pain clinic. So that was all about the chronic pelvic pain guideline. Okay, the incidence is that of 1 in 6. Okay, chronic pelvic pain is common and it affects 1 in